Thank you for joining today's webinar, The Importance of Microdeletions, with our speakers, Dr. Ronald Wapner and Dr. Susan Gross. Just a few quick points before we begin today. This webinar is interactive, so please join in. Feel free to ask questions during the webcast by just typing in the box on the lower right side of your screen. We'll answer what we can in Q&A, and the rest we'll be answering personally via email. There will be live polling questions throughout the webinar. Be sure to participate throughout the presentation and be sure to vote. And you can instantly see how your responses stack up with the rest of the audience. With that, I'll hand it over to Melissa.
Thanks. Welcome, everyone. I'm Melissa Stosek, Director of the Medical Education Department at Natera, and we're really pleased to be able to offer you this great webinar today. We're excited to have two special speakers with us for this to discuss microdeletions. So first, you'll hear from Dr. Ronald Wapner, who is Vice Chair of Research in Obstetrics and Gynecology for Columbia University Medical Center and is Director of Reproductive Genetics. Following Dr. Wapner, you'll hear from Susan Gross, and Dr. Susan Gross is Professor of Clinical Obstetrics and Gynecology and Women's Health, Pediatrics and Genetics at the Albert Einstein College of Medicine, and we're very excited as she has recently joined us as Chief Medical Officer at Natera. Today's agenda will start with Dr. Wapner on the importance of microdeletions. He will go over chromosomal microarray analysis and overview, the structural anomalies and their relation to CMA, the use of CMA in clinical practice, and variants of uncertain significance. Dr. Gross will do a talk entitled Panorama Goes Micro, where she'll discuss the NIPT technology differences, the microdeletions on the new Panorama panel, and what microdeletion screening means for your practice. We will have a question and answer session, so please feel free to ask questions, and at the end of the session, Dr. Gross and Dr. Wapner will help us answer. First, we'll start with a polling question, so please feel free to vote now using the polling function. True or false, increasing maternal age increases the risk of microdeletion. Great. So it seems like 3/4 of the audience says false, and that would be correct. So microdeletions are not related to maternal age, and that's why they're so important for our discussion today. Dr. Wapner, I'll hand it over to you.
Great. Thank you, Melissa. Good afternoon or good morning, depending on where all of you are. I'd like to start by visiting an old friend and probably one of the leading poets and maybe one might say prophets of at least many of our younger days, and that's obviously, as you see here, Bob Dylan. And one of the things, which is a refrain from his song, which really is the theme for what we're going to be talking about today, and it deals with all of what's going on in the genetic revolution. And it's, if your time to you is worth saving, then you better start swimming or you'll sink like a stone, for the times they are a-changing. And just like Bob Dylan was present in a revolution, it's important to realize that at the present time, we are all, sometimes we don't realize, in the midst of a major revolution, because the technology that's pushing forward genetics has really been overwhelming, and it's really been over the past 3 to 5 years. So what I'd like to do is review one of those technological advances and talk a little bit about how it absolutely positively will have an impact on all of our practices. So if we can go to the next slide, just a little bit of history. And it was only about 40 or 50 years ago when the only way we could diagnose a genetic disorder was to look at the phenotype or the appearance. As one sees in this picture here, we have a newborn baby. You can see that it's got his tongue stuck out because it's a relatively large tongue. There are a number of other characteristics, folds on the inner corner of the eye, the typical simian crease, and all of you know that all of these characteristics are consistent with a child with Down syndrome. However, all of these characteristics can also occur in individuals that don't have Down syndrome, so that if one only had the ability to look at the child, about 20% of the time you would make an incorrect diagnosis. Next slide illustrates that with time, we've significantly improved our ability beyond looking just at the characteristics of an individual. On the left-hand side of the slide, you can see a typical karyotype, and if you look carefully under the area that says G, the G set of chromosomes, you see there's 3 in the 21. And for a number of years, chromosomes looked like those cruddy blobs that I have illustrated here, and all you could tell was whether or not, just like with Down syndrome illustrated here, there were too many or too few chromosomes. With time, our ability to interrogate the chromosomes continued to significantly improve. And as you see on the right-hand slide, along came banding and along came stretched chromosomes. And with our ability to look more carefully at the structure of the chromosomes, because of the bands, we now were able to identify smaller changes than just an extra or missing chromosome. We could now see genetic abnormalities by looking at karyotype was limited to how well we could see things under the light microscope. The next slide illustrates, however, that no longer do we evaluate chromosomes just by looking at them under the light microscope. So we've moved from the area of cytogenetics into the area of molecular cytogenetics. And the basic principle for diagnosing microdeletions that we're going to talk about today is what's called chromosomal microarray analysis, or another term you might hear is comparative genomic hybridization. Those are the two underlying principles. But really, it's relatively simple. And as you see illustrated at the top, we have a chromosome. And what we are able to do is we can break the chromosome into actually thousands, hundreds of thousands, if not millions, of tiny little pieces. And then we can take each of those little pieces from the chromosome and put them onto a slide. Now, nowadays, it's done a little more sophisticatedly than just breaking the chromosome up and putting them into the slide, because now we know the whole sequence of the human genome. So at any particular location on a chromosome, if we know the sequence, we can just say to the computer, and that is put the sequence from chromosome 1 or somewhere on chromosome 1, or put the sequence from another area of the chromosome. So what we do is we wind up these tiny little chips, and in every little portion, and there can be millions of what we call probes, and all these probes are tiny little sequences that we know where they come from in the human genome. We then can take a sample from a patient, and we can mix it with the array, with the probes, and it will be able to tell us whether that particular patient is either missing or has too much of that particular location. And as you see illustrated in the kind of thing that looks like a bunch of dots, are each of the locations on an array, and then the computer can then ask and interrogate each of those locations, saying, is there a right amount of DNA from the patient? Is there too much or too little? So that as opposed to what I showed you before, which was a picture of really a molecular karyotype will look like today. And each of the little boxes represents one particular chromosome, and the computer has then placed at any particular location a representation of whether or not the patient has the right amount, too little, or too much. So really, what we're evaluating with chromosomal microarrays are what are called copy number variants. And all a copy number variant is at any particular piece of DNA, whether or not we have the right amount. So, as you see on the left-hand side, we have the banded karyotypes, which really served us very well But it's important to realize no matter how good you are, there's a limitation to seeing whether or not pieces are missing or overrepresented if you look at it under the microscope. So karyotyping for prenatal diagnosis in the best centers has a resolution that's around 7 to 10 million base pairs. That means that if there's any location in which something smaller, and 7 to 10 million base pairs, as you can imagine, is a lot of DNA. If there's anything smaller that's missing or overrepresented, you will not see it on a karyotype. As opposed to chromosomal microarray, in which the only limiting factor is how many particular probes we can put on a slide, we now can find resolution as small as 500,000 base pairs, and actually we can find pieces as small as 10 or 20,000 base pairs that are missing or overrepresented. So there's absolutely no question microarray dramatically improves the resolution with which we can look at chromosomes. However, the real question is this clinically relevant? It's nice, it's a cool technological ability, but does it really mean anything in the care of our patients? The next slide is what we've learned, and there's absolutely no question that these smaller pieces of DNA that are either missing or an extra piece are very, very important. And this started by the identification of microdeletion syndromes. And what I mean by a syndrome is an assortment of abnormalities, all of which come from the same genetic underpinning. And here, if you look at the picture under there, we see a little girl. She's got a relatively large mouth. You can see she's got some puffiness around her eyes. She has significant developmental delay, but despite that, she's got a very loquacious kind of outgoing personality. She happens to be very talented in music. For those of you that are familiar with this syndrome, this is representative of Williams syndrome, and we've learned that that's secondary to a missing piece on the long arm of chromosome 7, and that, however, is only 1.5 million base pairs that are missing, something that could never be picked up by looking at a karyotype. Listed also of other well-known microdeletion syndromes are DeGeorge syndrome, which we'll talk a little bit more about, many of you are familiar with, in which a piece is missing from the long arm of chromosome 22, Miller-Dieker, Prader-Willi, etc. Each of these are caused by a deletion that is way smaller than the resolution that you normally would see by looking at a karyotype. As a matter of fact, all of these are 5 million base pairs or smaller. All of these have severe neurocognitive abnormalities and significant intellectual disability. So there's really not a relationship between the size of the abnormality and how it can have a significant impact on the phenotype. More recently, we've learned that not only are there syndromes associated to missing DNA, there also are a number of non-syndromal microdeletions and duplications. And what do I mean by that? I mean that there's a small piece of DNA that's missing, but rather than a number of abnormalities, which we would call a syndrome, there can be one or two effects. As you can see, if you're missing a piece on the short arm of chromosome 16, that's been strongly associated with autism, a piece on number 1 chromosomes, intellectual disability, microcephaly, others that are autism and schizophrenia. So again, we have significant neurocognitive problems of these microdeletions, 500,000 base pairs, 800. So indeed, there's even very, very small abnormalities that can have a gigantic impact on the phenotype. I think the proof of the pudding, or kind of the information that showed how important this is, were initially done on postnatal congenital anomalies. All of them had entirely normal karyotypes, so the parents would have been told that there is no underlying genetic abnormality. But then when they did microarray, about 15 to 20% of those children just had something that could only be seen by a microarray that was accounting for their significant phenotypic changes. So it demonstrates the incremental information that we can get. Next slide, please. So let's look at ways that this can be integrated into practice. First of all, if we look at pregnancies in which there's an ultrasound anomaly and pregnancies in which the ultrasound is abnormal, but the karyotype is completely normal, none of the that we normally would see. And then we do an array, and there's 4 very, very large studies that have been done, and the numbers are incredibly consistent, and they all demonstrate that despite a normal karyotype, about 6% of those with major structural anomalies have an underlying microdeletion or duplication that's accounting for that. The next slide is just an illustration of a case, and I think it shows how important this is. For those of you who frequently look at echoes or fetal echoes, this is relatively straightforward. You can see we've got the right ventricle and the left ventricle that are marked here. There's a large ventricular septal defect, and then you can see the aorta overriding the ventricular septum. This is a typical tetralogy of Fallot by a fetal echo. Now, a tetralogy of Fallot is an easily repairable structural anomaly. The pediatric surgeons really have very good success with this, and if it were just a heart defect, then you would expect a relatively good outcome. Next slide, however, shows that this is not simply a heart defect, but the heart defect is just a marker for an underlying genomic abnormality, and in this case, the underlying genomic abnormality is a 22q11.2 deletion that some of you may also know as DeGeorge syndrome. The whole outcome for this pregnancy changes. First of all, almost 95 to 100% of these children have learning disabilities, about a third of which are severe, can be associated with other structural abnormalities, and something that we've learned recently is that this also can be associated with schizophrenia, and about 1 out of 4 of these children, as they go through adolescence, will be diagnosed with severe schizophrenia. So we have one gene that can cause a heart defect, but it's also associated with significant neurocognitive abnormalities, including what many people that take care of these children now say is the major problem they have, which is the significant psychotic abnormalities they have. All of this was because there's a small piece of number 22 missing. Now you might say, okay, I know that, so I could just do FISH for this. But the next slide demonstrates that 22q11.2 is just one of a number of microdeletions, all of which listed here have congenital heart disease, all of which, if you look down the right-hand side, have either intellectual disability or other significant cognitive abnormalities, but they all are different than 22q11.2. There are a number of well-known and well-described deletions now that are associated with heart defect, but can also have significant other abnormalities. So I think many of you are probably aware that the American College of OBGYN in December came out with a recommendation that for any structural abnormality identified on ultrasound, if you're going to do prenatal testing, you should no longer do a karyotype as the first tier test, that microarrays should be the first tier test. And you can see why. All of these would be diagnosed by a microarray, none of them by a karyotype. And even a karyotype with FISH is relatively limited. Next, please. This is another example of how important microdeletions can be. And if one looks here, you see this is a very, very typical club foot. We see this all the time. And until recently, most of us wouldn't be concerned. The rest of the fetus would look okay. There'd be no other abnormalities. This certainly is not something that's likely to be associated with one of the main aneuploidies, with trisomy 18s or 13s. And most of these are not associated, or at least when we were looking at karyotypes, are not associated with a significant genomic underpinning. However, in this particular case, next slide, the woman decided that she wanted to have an amniocentesis performed, and just as we would have anticipated, the amnio with the standard karyotype was a normal 46XY male, but she also underwent a microarray, and it demonstrated that there was about a 1.4 million base pair deletion on the long arm of chromosome 7. In this particular case, this deletion has been, I'm sorry, this was a duplication, I apologize. This duplication has been well described. It's described with club feet, it's described with the typical facial appearance you see here, and all of these children have significant developmental delay. So again, it's illustrating that as we get more and more sensitive or higher resolution genomic testing, many of the things that previously we didn't think were important because we knew that it was highly unlikely to find a major chromosomal structure abnormality, with microarrays we now can find important information that will dramatically change the way that we will be counseling our patients. Next, please. So there's really the question of, well, why don't we just offer microarray to all pregnant women? And there are many people that believe it's time to start considering that. Obviously, there are some differences or some major points we have to take into consideration. As opposed to making a diagnosis on a child in the postnatal period, when we identify these things in the prenatal period, we do not yet have a complete and accurate phenotype, and most importantly, we don't know the neurocognitive potential or the more cognitive development of that kid. So again, it's much easier to use these new genetic tests once a child's born. But then again, it also eliminates any options the parent might have with that information. Second of all is how patients would use the information. Postnatally, they use the information to make a decision about how to care for the child. When they get that information prenatally, they sometimes use the information to make a decision not to continue a pregnancy. And third of all, the desires of the parents. Postnatally, they just want to know what caused the problem and whether it's going to happen again. When they would use such sophisticated genetic information prenatally, what they're really saying to us is, I want you to assure me that my child is going to be totally normal. So I think there's no question, and I'm not suggesting in any way, shape, or form that this is not out, is that we always, as a society and practitioners, have to understand how this will impact patient care. Next, please. Next slide, if you would. So this is from a study that we did. It was published a couple years ago. And we now looked at pregnancies, not those that had a structural anomaly, but these are pregnancies in which ultrasounds were completely normal, nothing to suspect a problem. And in addition to doing the karyotype, which in all of these cases was completely normal, these patients underwent a microarray. And you can see that in patients sampled for advanced maternal age, despite a normal karyotype, somewhere between 1.5% and 2% had a significant microdeletion. Those that were sampled for positive combined screening, it's about 1.6%. Next slide illustrates that there's no question that some of these microdeletions are not as significant as others from the standpoint of a phenotype. So I've actually broken out those copy number variants that we saw that have the potential to cause significant neurocognitive impairment, and they occurred in about 0.8% of all pregnancies. So let me say this again. If you pregnancies that we're presently doing invasive testing on, about 1 in 125, if you just take those with neurocognitive abnormalities, or maybe as many as 1 in 60 have a significant genomic abnormality that will be impacting the phenotype. So this is not something that is infrequent. This is something that is very, very frequent. And I think Susan's going to give you some information in her discussion about exactly how frequent. Next, please. So I think hopefully I've been able to make the point that with this improved resolution has come a lot of important information. But nothing comes without some cost. And I just want to review briefly that there are two things as we learn about this new technology that we have to understand will make counseling patients, on occasion, difficult. One is that we can sometimes find findings of unknown significance. In other words, a deletion or a duplication that we just haven't seen before. We don't know what it means, and we're going to have to tell the patients that we found something that we're just not sure exactly what the impact is going to be. And the second thing I'm going to talk about briefly is variable expressivity. Next illustrates, however, that findings of unknown significance are becoming much less common. And the reason is that as we have done more and more arrays, we have gathered large databases and a lot more information, so that we're now much better able to 5 years ago. And as you can see, that this title VOS means variance of unknown significance. We looked at a group of patients, first in 2007 and then in 2012, and we said how many of the findings were of uncertain significance at that time. And you can see the dramatic improvement. It was about 2.5% in 2007, down to about 1.5%. So, and that number is probably continuing to shrink. So as we gather more information, many less of these findings are we going to have to tell patients we're just not quite sure what it means. The next slide demonstrates, however, working with variants of unknown significance, actually something we've dealt with all along, even with cytogenetics. Many of the things I have listed here counted for about 1% of CVS or amnios even 5 or 7 years ago without arrays, just identified cytogenetically. We have to tell the patient we're just not sure what this means. So this isn't anything new. It's just a different set of things that we need to learn about. And then the final example, next slide please, is what we call variable expressivity. Now, as you know, there's two genetic principles. One's incomplete penetrance, in which a parent can pass a gene on to a child and it'll have no effect whatsoever, or variable expressivity, in which the same gene can have multiple different effects. This occurs all throughout genetic disorders, but it also occurs with the identification of copy number variants. Here we have a case in which, if you see somebody's getting ahead of themselves, if you see the case with the question mark, that child had a CVS. It showed a deletion of the short arm of chromosome number 16. This had been well described in the literature. It's associated with autism, severe epilepsy, and developmental delay. But as always, although the vast majority of microdeletions and duplications are not inherited, in some cases they are, and in this case we checked the father, and he also had the same thing. He also had a PhD in immunology. So basically we now have something described to have significant impact on the development of the kid, with a father that apparently was normal, although on closer evaluation it turned out that he had ADHD, he had significant other abnormalities. And then we went and tested the other child, as you can see there, and that child had the typical spectrum that I had described. So you can see the same gene can have multiple effects in the same family, and that's called variable expressivity. There's nothing wrong with it. Well, it makes counseling very, very difficult, but it's something that geneticists have been dealing with for years. And as we start adding copy number variants to our prenatal armamentarium, this is something we're just going to have to talk to parents about. That a lot of this information, the risk for autism, the risk for learning disorders, the risk even for epilepsy, are things that many people would say, why do we want to know these things in utero? But I think that all of us have to agree that with the increased resolution that we have with our prenatal tests, we will find this. It used to be that we only looked for severe things, and the only options we gave parents was continuation or termination of a pregnancy. But I think there's no question now that we now are going to find things, and having that information can significantly alter the outcome for these children. Knowing that a child has an increased risk for autism, early intervention has been demonstrated to make a gigantic difference. Learning disorders, again, early intervention makes a significant difference. So this is very, very important information. But now it's going to be information that can be used by the patient and the pediatrician, which is exactly why we want to do prenatal testing, to improve the outcome. So this is what microdeletions and duplications can do. I think I think we can make the point that they really are something that is an important part of prenatal testing. So I think Sue now is going to talk a little bit about how these can be diagnosed and give you a little more sense of their frequency. Sue?
Thank you very much, Ron. We're going to move into a polling question again. So true or false, most babies born with microdeletion syndromes are born to couples who have a family history of those disorders. Now I will hand over to Melissa to review the polling results.
So the polling question pops up in a separate window. Overall, 92% of people say that is false, that babies born with microdeletion syndromes are not, in fact, born to families that have a history of the disorder, and that is, in fact, the correct answer. We're going to continue with polling questions. Sue, do you want me to take it? True or false?
Absolutely.
Deletions are uncommon. Okay, answers coming in here. It's about 80% say false to this question, which is the correct answer. Microdeletions are common, and Dr. Gross will tell you exactly how common they are shortly. Next polling question, true or false, microdeletions can cause severe intellectual and physical impairment. Woohoo, almost 100% say that is true, which is correct. And last polling question is 22q11.2 deletion is more common than cystic fibrosis and trisomy 18. True or So again, about 80% of this audience says that is true. And Sue, do you want to take a comment on that?
So it is more common than cystic fibrosis and trisomy 18. And with that, we're going to segue into my part of the talk today. It's called Panorama Goes Micro, but I really need to start off by saying that it really is a privilege and a pleasure to discuss this topic with you today. It's been decades, actually, that we've been screening for aneuploidy. Then we have single gene disorders, cystic fibrosis, Fragile X, and here we are in 2014. It's an incredible time to be practicing medicine, really because of the breakthroughs in science and technologies related to genetics. 2014, I can talk to you about microdeletions screening as a reality. So we'll go ahead and get into the heart of the talk here. So this is a picture that is actually from the Human Genome Project, originally educational picture, and it's the most wonderful thing. DNA really is the molecule of life. Its brilliance is in its simplicity. We all have 46 chromosomes in our cells. The actual DNA is incredibly long. It's meters long, which is why it has to be packaged up into the chromosomes. And there's 3 billion base pairs, those famous letters A, T, C, and G, that make us who we are. These we transcribe, we have proteins, and that is really the molecule of life. It's also the miracle of life. So we use that slide is going to inform everything I speak to you about for the next half hour or so. So we're talking today about non-invasive prenatal testing or screening, and the technology really does make a difference. And I'm going to just briefly review what is available out there and how different methods are being used. I'm going to start with the other methodology that's being used for microdeletions. It's based on a counting system. And what we do is take a look at this screen. what you see is that DNA, that double helix, and that's really what counting system is about. It takes those sequences, and what it does now is, if you take a look on the screen, it's going to pull out the chromosome 21 sequences, those pieces that we saw, and we also can look at those and reference them against another chromosome. In this case, chromosome 3, and you'll see there's more chromosome 3 than chromosome 21. It happens to be a bigger chromosome. What we then do is pull these apart, and you can actually just measure them. There is a ratio that there is more chromosome 3 than chromosome 21 sequences. Let's say an 80 to 20 balance. If we see 80 to 20, we're looking good. That would be euploid. But what happens if the balance is off and you see an extra 21 sequence? And in that situation, the concern is that there is now a risk for aneuploidy. Again, balance is off. Instead of the 20/80, what we're going to see in this case, for example, would be a 25/75 break. And it's a simple way of looking at just basically the difference in amount between sequences from, in this case, let's say 21 versus chromosome 3. So how is panorama different? So in the counting method, again, just to review, you have a certain amount of 21, and in the case that you have a little bit more over a certain baseline score or measure, and you reference it, you can call it a positive risk. The way panorama works, the panorama technology is very different. In the panorama design, what you can do is actually separate mother from fetus, or actually technically placental DNA. Being able to distinguish between placental DNA and maternal DNA makes all the difference. And again, with the next few slides, you'll be able to see why that is and the impact on microdeletions. So again, let's go back to that sequence that we saw before. But the difference is, instead of looking at longer strands, we're really looking at a single base pair. You can see in this case it's pointing to the T, and it's all about these base pairs. Now, what is a SNP? Because that's really what you hear so much about, is a SNP. So let's take a look and see what that is. So in the case of a sequence, this is actually terrific, as you can see on your screen. This is publicly available. You can easily go online and get it. This is what it looks like when you look at a gene. And this is, I believe, from Tay-Sachs, but basically all it is, the Tay-Sachs hexosaminidase gene, that is responsible for Tay-Sachs disease, but what you really see here is just those letters repeated again and again. Human Genome Project was out. A lot of the science we do now is trying to understand what those letters are. But if you take a look, let's pick a site there on the screen, and let's take a look at that. Now, this is a SNP. If you take a look, okay, I'm going to point you over now to a T. But sometimes a T can actually be another base pair, okay? And in this case, it's a C. And that's a SNP, or single nucleotide polymorphism. Now, the wonderful thing is that SNPs are very, very important to diversity. It only happens 1 in 1,000 times or so, but it helps explain a lot of the reason that we all look differently, even though we're all one human family. And that is actually the basis of the panorama test. Now, again, why does this matter? I'm going to show you the karyotype, and again, you heard Dr. Wapner refer to these old karyotypes and how crude they are compared to what we can do now. But I'm going to use it to illustrate, and I'm going to show you now a chromosome pair. Remember, we get one from our mom and we get one from our dad. Now, the idea here is that we pick SNPs, those single nucleotide polymorphisms that can be either one base pair or another. For example, a C or a T. For our purposes right now, we're going to call it A or B. And it has multiple possibilities. So let's get started here. You can see, for example, that you can be an A or a B, an A or an A, or a B and a B. And we can layer those all across the chromosomes. They exist actually throughout the genome, but the idea of the panorama approach is that we can decide which SNPs we want to look at. And why does this matter? Because it can give us a very precise insight and look into areas of interest. So, for example, we can look at the common aneuploidies, such as 13, 21, 18. We can look at X. We can look at Y. And the remarkable thing is that we are capable of doing this 20,000 times over. Another unique and remarkable feature about Panorama. So the issue, however, becomes we have a lot of data points, because remember, I showed you 20,000 SNP locations and all these possible combinations. And imagine what happens if we throw in the fetal DNA as well. It only becomes more complicated, which brings me to the second remarkable part of Panorama technology, is that using a very complex but excellent algorithm, we can separate mom's DNA from the fetal DNA, and we do that by spinning off the blood, and we actually genotype the mother. Then we go back in the plasma and we see what's there, and we can separate now, basically subtract mother from fetal, and we can use this algorithm to actually estimate and try to determine which genotype the fetus is out of multiple possibilities, and from that we derive a personalized risk score for each condition. Now, the reason that that is so important is we can do it anywhere we want to on the genome. So for today's discussion, this is why what we have developed here is such a remarkable breakthrough and allows us to look with incredible precision at the microdeletions. So I showed you before this slide where we were actually able to look at the chromosomes of the mom. And the same way we can look at the chromosomes of the mother, we can also look at the, the same way we can look at the chromosomes of the fetus for 18, 21, and 13X and Y. We can also do it for 22Q. So again, we can put those 20,000 probes wherever we like. We can do it actually on a subchromosomal level. And if you take a look at 22Q, that's how we do it. So I'm very pleased to show you the analytical performance. It's absolutely remarkable. You can see it very clearly here. For sensitivity, well into 90%, all across the board for the 5 microdeletion syndromes that we're looking at currently. From 22Q, 11.2, Prader-Willi, Angelman 1P36, and Cri-du-Chat, you see sensitivities all the way down well over 90%, and 22Q11.2, 95.7%, specificities 99%, all the way down this slide. But the next slide I'm going to show you, I believe, is actually the most important. And that slide is that, yes, technology does matter. we can do this. But does that alone justify testing for microdeletions? And I have to actually thank the medical community, the professional community, those people who came out in public, in private, to say that yes, we can do microdeletions, but just because we can do something, should we do it? And I would like everybody on who's watching the webinar today to know that we took that to heart and that our approach was really based on this slide. If we're going to do this, we have to justify why we're doing the testing, and we have to really do it in a way that matters and it's done the right way. So let's start the talk again. And really what I'm here to talk to you about is, what does microdeletion screening mean to your practice? Or perhaps even more important is what follows. How does this help our patients and improve health of the population? And I hope to make the case over the next few minutes that at Natera we really have taken this approach, and I think we have done this the right way. So this is a slide that many of you have seen. We've been handing it out. It's readily available. It's a very busy slide. I'm not going to go through it. But it makes the point that at the left side of the slide, there's incidence, sensitivity, specificity. Let's go to the right-hand side of the slide. That's what matters. How does it actually affect those individuals who are affected? And if you take a look, really what you want to think about and look at is what's on the right-hand side, which is lifespan, developmental delay, heart defects, and other abnormalities. Those are the things that actually really matter to our patients. And number one, if you're going to screen, these disorders should be severe. You want to screen, and I think Dr. Wapner did this very well, and I'm very appreciative for his introductory talk. You want to be screening for disorders that actually matter, and these microdeletions really do matter. 22q, many of us are familiar with because of prenatal heart defects that we can see on sonography, but they are all associated with significant issues, disabilities, things that matter. Now, this segues into the polling question we had before. It's that these disorders, they need to be common. And this really speaks to, again, a key feature of any screening program, is you want to pick disorders that appear often enough in the population that they have a significant effect, not just in a single practice, but population-wide. And you can see here the polling question answer. 22q is quite common. In fact, it's after trisomy 21, it is the most common issue that we are currently going to be screening for. 1p36 also is another common microdeletion. And again, more common than SMA. Many of you on the line are screening for SMA today. So I think we can make the case that these are high incidence. Even more striking is that, again, remember the polling question? These are not age-related. They are across the board. And when you put them together, the incidence is probably around 1 in 1,000. And this is the famous Hook graph and Hook data. But as you can see, as women get younger, aneuploidy is not the big issue. These microdeletions, in fact, are, and in many ways carry more significant morbidity and mortality issues. And again, they matter. So let's move on to the next issue. Which microdeletions should we include? So this is not a trivial question, and again, it comes back to the same issue. Just because we can, should we be screening? So the clinical significance we spoke about, the population incidence, and again, and it may be even higher using Dr. Wapner's data, and 22q11.2 really is a good example of a disorder that many children look normal at birth. They go undiagnosed. This can go on, by the way, for months, for years. And meanwhile, they have very significant disabilities that if we knew before the child was born could make a big difference. And let's talk about those briefly as well. So, for example, if we knew that child has 22q, probably best to deliver a baby at a level 3 facility. Problems, no live vaccines. We could actually kill a child, as we all learn in medical school, with live vaccines when you are immunocompromised. These children can have issues maintaining calcium. They can have seizures that lead to only more cognitive impairment. Checking the palate to address malnutrition and speech development problems, one would think would be trivial, but it's not at all. It often can be very subtle. And most important, for these families, we call it the diagnostic odyssey. They can spend months and sometimes even years trying to find help for their children, where with a simple screening test, this could all be avoided. So again, here's a situation where early detection matters. Now, rigorous analytic standards. I just showed you a slide earlier on showing that we are consistently over 90+% sensitive, greater than 99% specific, irrespective of size. We're well validated. We reflect fetal fraction distributions. And again, 22q11, very striking data. But you know what? In the office, actually, patients aren't talking about sensitivity specificity. What is it that we really care about, both as physicians and certainly for our patients? Doctor, if I'm high risk, what does that mean for my baby? That's the real question, and so we went ahead and addressed that as well. In other words, just having terrific sensitivity specificity is not necessarily enough, and I will now show you why that's in fact the case. So we often confuse sensitivity with positive predictive value. Sensitivity is based on the condition itself. So when we say something is 99% sensitive, it means that out of 100 cases of a particular disorder, we can pick up 99. But that's not what's happening in the office. What's happening in the office is, out of all the patients that have screening, how many of those actually have the outcome that we are looking for? And that's a very, very different matter. So while the condition drives sensitivity, it's actually the test outcome that drives positive predictive value, and that's what is most important for our patients. In other words, how many amnios do I need to do to pick up one of these microdeletion syndromes? And we really need to be able to tell our patients that answer before we offer any test, and certainly microdeletion testing. So we, in fact, did the math and only included those where we could focus on the patient, and bearing in mind that the rarer a disorder, the less likely, the more rare the disorder, the positive predictive value actually will decrease. Two is take into account how common a disease is, and then look at the analytic parameters that I showed you before. So let's actually just get real here and be specific. 22q11.2 happens 1 in 2,000 times. Not all those cases, by the way, can be accounted for with the large deletions. There are some other causes of 22q where you're looking at smaller deletions, and we take that into account as well. And we actually can give a risk figure. The odds of being affected with a positive result, OAPR, is 1 in 18. The risk, 1 in 19 that the fetus is infected. In other words, we can look the patient in the eye and we can say that we will need to do 19 amnios, or CVS, to identify this, but we have to compare this to screening. It is far better than current serum marker screening. Even in good hands, probably we have to do 20 or more amniocenteses, and again, depending on the type of screening we use, that might not even be that good. So that was a standard that we felt we needed to meet. Next, how do we integrate into practice in a responsible, efficient way? We responded to providers, and in fact, this microdeletion panel was launched to a smaller pilot program of providers who gave us excellent feedback. If any of you are on today, I want to thank you. We listened, and that is why we included positive predictive value and risk scores. The patients are concerned about outcomes, so the question keeps coming up, how do I speak about this in my practice? Is this going to make the office visit even longer? Is it going to be more complicated? And what we're hearing from doctors who've already integrated this into their office practices, the way you think about this is we don't give tremendous detail with the other issues that we screen for, the other problems. What we do rather when we speak to our patients is give them the information so that they can make an informed decision. And in fact, microdeletions are similar to disorders we already screen for. They're clinically significant. They have physical and cognitive impairment. They may be missed with routine screening modalities, and knowing may aid the pregnancy and newborn care. And always to remember that providers offer testing. We do not recommend, we do not force women, but we provide information so that women can make informed choice. And that's really, if you think about it, microdeletions are not really that much different. We screen for 5 microdeletions now. Again, 22q, as I mentioned, has cardiac indications, but we included 4 others that we felt met our very high standards of both analytics, but also focused on the patient. And to be able to actually do this well, we had to, again, validate all of these. Just waiting for the screen here. And the way we did this is use natural samples supplemented with artificial samples or synthetics, which are done often when we're dealing with rare disorders and validating tests. And even our validation was done in a way so that we could generate enough samples so that we could actually give you sensitivities and specificities for each of the disorders. The way this is done, by the way, is again a remarkable system that was developed in Natera. And it is a way of breaking up DNA into pieces that accurately reflect size profile that we see in normal biologic populations. And unlike sonication, which is the way it's usually done, we are able to maintain and know that the size is what we see in real life, and we were even able to break it up into the distribution of fetal fractions that we see in large populations. So in fact, it gives us the most accurate way of reflecting a group of patients that there is actually no other way to accomplish. Now, again, these are validated, and we are validating the size that we, again, can give excellent analytic characteristics for and performance characteristics. We do believe we'll be able to validate even smaller deletions, but again, we will not do that until we are really fully comfortable that we are doing it right. So I'm going to bring us full circle again to show you the sensitivities and specificities that we have for our microdeletion panel. And now I can show you the slide and say, yes, the sensitivities and specificities matter. They are excellent. And we feel that we can use the microdeletion panel. We can promote the microdeletion panel for use, knowing that we took into account all the other parameters that are so important for safe and excellent patient care. And just to wrap up, again, to summarize, we chose a panel that the microdeletions were severe, common, equal risk across all populations, younger women, older women, essentially low and high risk, microdeletions that can go undiagnosed and can lead to harm, early intervention that can really make a difference. And again, the panorama test is validated to screen accurately, responsibly, and risk-free. And my last slides are the slides I'm actually most proud of. We have worked very, very hard to be the responsible face of prenatal screening. And I'm very proud to say that we have partnered with the 22Q11.2 Foundation that organized by parents, caregivers, people who really advocate on behalf of these children. And Natera is very proud to be a partner to help educate about microdeletions, specifically 22Q, and to arrange for comprehensive care early in life, to provide support for parents and families. And really, just to conclude, it's really an incredibly exciting time. We're going to learn so much, but I want you to look again at that child there. That's really what matters in the end. We're here to prevent disease, to promote health, really for both moms and babies. And I just want to thank everybody for joining in today, and we're now happy to take questions and provide some answers.
Great. Thank you, Susan. So I know we're a few minutes over. We are going to continue to answer questions, so if you can stay, feel free to continue to join us. And if not, we will send the recording out to everyone that was on so you can hear the answers to the questions. And if your internet connection wasn't working well and you couldn't see slides, then you will be able to see them on the recording. So we have a lot of questions. The contact information is here in case you don't get your particular question answered. I am going to start with one question for Ron, and that is, Dr. Wapner, the structural anomaly cases for microarray. You had said that there was about 6% of cases chromosomal microarray analysis after a normal karyotype in the presence of a structural anomaly. And the question is whether or not this is across gestational ages and whether that number is the same regardless of if the patient is 13 weeks or 20 weeks or in the third trimester.
Yeah, that's an excellent question. The majority of the information that we have is second and third trimester. Although I would assume, and again, I can't be certain, that it would hold the same for first trimester. I think also it varies depending on what the anomaly is. And when the anomaly is a cardiac anomaly, actually the incremental findings is over 15%. So that there really are some anomalies. In addition, actually skeletal dysplasias have a higher frequency, and for some reason, most recently, people have realized that renal anomalies have a high frequency of microdeletions and duplications. So it does depend more on the anomaly than on the gestational age. Surprisingly to us, we did look at cystic hygromas, kind of hoping that that would be an answer, because we were all frustrated when we have a cystic hygroma in which the chromosomes are normal, looking for more information to give parents. That was not as revealing as some of the other anomalies, and that was only in the 3 to 5% incremental range. Susan, are you there?
I sure am.
Hey, can I ask you a question? I think this is very important. I still think that, and I'd like your opinion, if one finds a structural anomaly on an ultrasound, my sense is, although non-invasive prenatal testing is wonderful, it's still a screening test, so that if there's an anomaly on ultrasound, invasive testing with a microarray would still be the way to go?
I thank you for bringing that up. So it emphasizes 2 points. First of all, yes, this is a screening test, and I could not agree more. I was very pleased that ACOG came out with that opinion. If with anomalies, most certainly, a screening test, again, we offer, but definitely the way to go there is a genetic counseling and a high-risk assessment. So I could not agree more. The you know, when we look at the big picture here, one of the most interesting things I believe that is going to happen is because there's no age dependency for the microdeletions, it really affects populations across the board. I would ask you what your opinion is in terms of how this will break down vis-a-vis low versus high risk.
Yeah, I think that, and the slide that you showed that demonstrated the frequency of genomic or abnormalities based on maternal age makes the point incredibly well. And that is, the younger the patient, the less likely any genomic abnormality is going to be a major aneuploidy like 21, 18, and 13. And women over 35, of all the genomic abnormalities, somewhere between 75 and 90%, depending on how old they are, would be 21, 18, 13. However, for a woman 25 or 23, only about 20% of chromosome abnormalities that they have are going to be 13, 18, and 21. The rest are going to be much more subtle, smaller things that will not be picked up if you just screen for that. So my gut, and I'd actually like your opinion, is as we start offering this to younger patients, we really have to take into consideration that there really are other chromosome abnormalities that are equal to, if not more important, than Down syndrome 18 and 13. The reason that we started screening with those is because that's what we've always screened with, but I think we've come a long way since then, and I think your slide makes the exact point that the younger people are really, if they want to reduce their genetic risk, we got to do more than just look for those major chromosomal problems.
That sounds great. So Sue, can you comment on, for the microdeletions, especially for 22q, what might be some examples of early intervention that can happen for these patients?
Oh, certainly. So again, to go back, and it does appear in the slide set, and I'm very grateful because this was exactly the point of the talk. There are issues that one needs to consider prior to birth. So if you do screen and you identify this, 75% of these children will have heart defects. Out of those, they will not always get picked up prenatally. If you know to look for them, you can refer for fetal echo. You can be properly prepared at the time of delivery. You can work with the family. You can work with the intensive care units, pediatric units, and perhaps that baby needs to be born at a level 3 nursery. At the time of delivery, you'll be on standby. You'll know to watch calcium levels in the baby. Again, that can be associated with seizures, often does not get picked up. And the case of checking to make sure that there's an intact palate, again, we often see issues related to palate that are obvious, but is not necessarily so. This would give an opportunity to assess because it can be important related to all kinds of issues, not least of which is appropriate feeding. And again, I did mention the live vaccine, and just in general, these children can have issues related to immunocompetence or lack thereof. So there is a perfect indication where early intervention and knowledge could make a large difference so that these kids get every possible advantage that they can starting out in life.
Melissa, may I dare direct a question to you? Because I'm not sure anybody said at the beginning, but you are a genetic counselor. And as we add things like microdeletions to the screening tests, should we counsel our patients differently? What should we tell them about this, and what are the risks and benefits that they should be aware of?
Yeah, so I'm happy to answer, and I know Sue has some feelings on this too, so I'll send to her afterwards. But I think, yes, it needs to be something that's discussed with the patients. the key point that I will point out, which is really the difference between, in my experience, counseling for chromosomal microarray analysis during an amnio-CVS and counseling for NIPT for these microdeletions, is that that risk for uncertain disorders is not present. So the risk for chromosomal microarray that patients are most concerned about are getting a result that's of unknown clinical significance. For NIPT, that changes and becomes the risk of a false positive. So the way you counsel them are different. And I think patients who are getting screened are getting counseled already that there are false positives for Down syndrome, and certainly our microdeletion testing has many fewer false positives than even a first trimester screen, which we're all used to counseling for, that it becomes counseling the patients on the risk of false positives, on the importance of confirming any positive with an invasive test or testing on the baby, with the balance of the risk of invasive testing, which is now low, compared with the ability to detect more deletions, and also just making sure that they understand that the severity of these disorders that we're adding are now as severe or more severe than Down syndrome. And patients don't understand the complexities, and some physicians don't understand the complexities. So it becomes taking the patient and saying, listen, we have this whole panel of disorders, and these are as severe or more severe than Down syndrome. And if you're interested in knowing about Down syndrome, then likely that patient is interested in knowing about these as well.
You know, two things, if I may comment before Sue does, or three things maybe. Number one, when we as physicians say Down syndrome, we're pretty much talking about trisomy 21. But I think when you say to a patient, do you want to test for Down syndrome or do you want us to test for more things, lots of patients don't really understand the they use the term Down syndrome as kind of a generic term, and they think it means any kind of developmental delay. So I think as we start offering or now have the opportunity for a lot of these things, it's going to be important that patients understand, just as you said, that Down syndrome is not every conceivable kind of problem. I think also, and you kind of alluded to it, but I just think it needs to be emphasized, however, that no NIPT tests, no matter, at least as they exist right now, can identify all the microdeletions and duplication. I think that you've made an excellent choice of ones that are, for all the reasons Susan said, they're common, they're severe, et cetera. But I think it's important in the counseling session with the patients that they understand that it isn't testing for everything, because the worst case would be to have something that's not on your panel, and then they're going to say, well, they told me they're testing for microdeletions, et cetera. So it's important that the patients also understand the limitations of the testing. The third thing is that many of these are severe, but even amongst those, there is some variation in the expression, and I think the example that Sue gave with 22q11.2 is important. There are some of the parents that weren't even diagnosed until they had an affected child. They had the learning disorders, they had some psychological abnormalities. So I think that patients need to be aware that there can be some variation. So that's I think I can't emphasize enough that counseling, making sure that patients understand the tests, et cetera, is really important. I guess I'm a bit, I know that takes a lot of time, but it really is important.
Yeah, well, my comments then can be brief. So first of all, listening to Melissa basically discuss how one counsels should hopefully make everybody aware as to the value of genetic counseling as an actual profession. That was really well done, Melissa. Thank you. And also, Ron, your point is so valuable and so important. This may finally help us stop using Down syndrome as a placeholder and as a reference point, that the Down syndrome is, is the problem. Down syndrome is not the problem. There are children, affected with Down syndrome. But because of how things have developed over the years, that's become a way of us identifying and not using appropriate language. The way Melissa laid it out is exactly the way we should speak to our patients. There are various disorders. Down syndrome is just one of many that we are now capable of screening for. And, if nothing else, perhaps microdeletions will help us appreciate that and how important language is and how respectful we need to be of children and families where there are genetic disorders. So I think that, I'm hoping as a medical community we'll do better with that going forward.
Great, thank you. Okay, so I think that's all we have time for today. If you did submit your question, we will do our best to answer those directly to you. I've been trying to answer some of you, but I will send a response to everyone that asked a question, so be on the lookout for that. And of course, you see our contact information here if you want to send us questions directly. Thank you so much, everyone, for joining.